Okay, so you're going to have a series of lectures on the nursing process and care planning, but they're going to be a little bit different. They're not going to be quite as long, and it's going to be more how to connect this to the care that you're already giving. So first of all, you need to understand what the nursing process is. So let's talk about the nursing process. It is a structured way to view or to look at the way we give care. If we go in and we follow orders, pretty much anyone can be trained to do that, right? If we go in and we just click tasks off of a list, anyone can learn to do the task of nursing. The most important piece of nursing is not necessarily starting that IV or giving that medication, that hands-on skill. The most important piece of nursing is up here, okay? So we have a defined way of looking at or of organizing the process that we go through in caring for patients. The nursing process begins with assessment, and it has steps, but those steps are not linear. We move back and forth between the steps. Sometimes we find something that swings us back around to the beginning of that. So I don't want you to think I've got to work all the way through the steps and then go back and start over. We're moving from step to step much more fluidly than that. So the nursing process has 5 steps. It's assessment, diagnosis, planning, implementation, and evaluation. Okay, we're going to look at a couple of models in a few minutes, but I want you to think about those. First, we assess the patient. When you get your patient, the first thing you do is go and assess them, right? And then you decide, based on your assessment, what their priorities are. Okay, when we talk about nursing diagnosis, that's putting a formalized name to that patient's nursing sensitive needs. And then you decide what your goals are for that patient. What do you want that patient to look like after your care? What do you want them to experience after your care? And then you decide how you're going to do that. So that's the planning piece. How am I going to accomplish these goals? How am I going to correct or make this problem better? And then you actually do it. Okay, this is the hands-on, what am I actually going to do to accomplish those goals? And then you look at whether that was effective. So as you're moving through that process, you may run into something that changes your priority, for example. You go in, you assess your patient, they have pneumonia, you hear crackles, your priority might be to help get their airways cleared out. So you create a plan based for that. But as you're doing your assessment, you notice that they have a new wound that no one has noticed, or you find out that they're being abused at home. And so that may either add additional or change those priorities. So this is not a straight start to finish process. The term they use is iterative. It's a process that we use fluidly, moving back and forth from those things. So I'm going to look at a couple of models and talk about that process. So the NCSBN is working on an updated NCLEX, and the goal is, they're calling it Next Gen, and the goal is to measure clinical judgment. Okay. So we have traditionally had the nursing process. We assess, we analyze. This is where the diagnosis part comes in. Understand that nursing diagnosis is not the medical diagnosis, and we're going to get a little bit more in detail about that in the next lecture. And then we plan, and then we implement that plan, and then we evaluate. But remember, this process is not a linear process. We move back and forth. Okay, I may be doing all of these steps each time I'm in the room, and constantly reevaluating where that patient is in relation to my goals of care. So the clinical judgment model has several layers. Okay, I want you to look at layer 3, and we're going to compare it to the nursing process. And the clinical judgment model doesn't necessarily replace the nursing process, but this is about how we use the nursing process. When we talk about assessment, layer 3 right here, the first thing we're going to look at, or we want to measure with the clinical judgment model, is recognizing cues. Okay. Do you, as the nurse, recognize things that indicate a particular problem? Do you recognize first that something might be wrong? Or cues can be something that's right, but then can you analyze those? An analysis right here, we start looking at nursing diagnosis, or identifying a nursing problem. Okay. And then we move to prioritizing hypotheses. Okay. And that means, what do I think is going on with that patient? Okay. That's the diagnosis part. Generating solutions is planning. Okay. Taking action is implementing, evaluation. Okay. So I want you to look at that connection. So when we talk about, when we're in case studies, when we're in simulation, one of the things that I want you to be able to do is recognize what's going on with that patient. I want you to see the picture of that patient. So for example, we have a patient who is admitted to the hospital for pneumonia. So we go to that patient's room and we perform our assessment, and the patient is slumped down in bed. Their oxygen is off. Their O2 sats are, 89. They have a congested cough. They feel warm. When we listen to their lungs, we hear lots of crackles and wheezes and not fantastic air movement. They complain about being nauseated. They complain they haven't had a bowel movement in 3 days. They may have a wound on the heel, okay, on the left heel. So when you get all of that data in together, do you recognize what the highest priority data is? Do you see a pattern there? So the pattern that I see, let me turn this down so I won't interrupt us. The pattern that I see, I can put a fancy name to it, and we're going to talk about NANDA labels and nursing diagnosis, but I want you to look and see a pattern of things that nursing care can address. Okay. We are not diagnosing that patient with pneumonia. And as far as interventions for the pneumonia, we're following orders. The provider leaves orders for the antibiotics, right? But what does pneumonia do to a patient? Nurses take care of patient responses. So what's a patient response to pneumonia? Well, patients with pneumonia frequently have a lot of congestion. They have a lot of mucus that's stuck in their lungs and can't come up. So they may have an airway issue, right? We need to get their airways cleared. They also have inflammation in the alveoli, the lung tissue itself. The alveoli, where gas exchange occurs, is inflamed, and it's got gunk in it, and it's kind of collapsed, not expanding well. What that means is they're not exchanging gas as well. So do you see why you need to know the pathophysiology of pneumonia to understand what the nursing sensitive problems are? Okay, what a nurse can address. So for most patients with pneumonia, we're going to be assessing. If I know the patient is diagnosed with pneumonia, I want to assess their breath sounds really well. I want to assess their O2 sats. I want to assess their work of breathing, and I want to assess them for signs of hypoxia. Okay, what does that look like? They may be confused. What does work of breathing looks like? Think about retractions, think about grunting. In little bitties, think about nasal flaring. Okay, breath sounds. If they're not moving air, they're not getting gas exchange. So when I look at all of those pieces for this patient with pneumonia, what do I see? Well, I see that the patient is in a poor position for lung expansion. They have airways that are tight, and probably have some mucus and stuff in them, because I can hear that when I listen. Okay, they're not getting enough oxygen. So that's my analysis. This patient isn't getting enough oxygen right this minute. Is that a higher priority over their bowel movement and their sore on their foot? Probably so. Okay. They're not getting enough oxygen. So what can I do to fix that as a nurse? Well, the first thing I want to do is get them in a position so their chest can expand. And then I want to get some oxygen back on them. We can apply oxygen without an order. This patient actually has oxygen in soft, but if a patient is hypoxic, we can apply oxygen without an order. We have to contact the provider after we do that. We don't wait around until we get hold of a doctor and then start oxygen. We can apply that and then get hold of the provider. I'm going to get some oxygen on them, and then I'm going to see maybe what are some things that we can do to help open up their airways. This is where we might have some dependent interventions. They might have an order for a bronchodilator, so I might get get their nebulizer going, or they might have an order for a rescue inhaler. So we may have some dependent interventions. I'm going to encourage that patient to cough up mucus instead of trying not to cough. So I don't want to suppress their cough. I'm going to encourage them to take in plenty of fluids as long as they don't have congestive heart failure or renal failure. I want them to take in plenty of fluids to loosen that phlegm up. I want to encourage them to use the incentive spirometer to fully expand all of their lungs. Those are all nursing things that I can do to improve their airway and improve their gas exchange, right? So that's the implementation piece. That's the action. That's what I'm doing. And then, did those things help? And you may be evaluating at literally every time you see that patient. Do I want to wait an hour and then evaluate whether this patient's O2 sats are better? No. I'm going to straighten them in the bed. I'm going to put oxygen on. I'm going to see if their O2 sats are better then. And then if that's not enough, I'm going to see, do they have a PRN bronchodilator? What other things can we do? I may get the provider involved if I don't have any PRN orders that can help. So I'm evaluating, and then I'm going back to the intervention, and I'm reevaluating. I want to get the oxygenation fixed before I leave that patient right now. I'm also going to have goals for them having clearer breath sounds. So I'm going to evaluate that later on in my shift. Are their breath sounds getting better with using incentive spirometer every hour and drinking fluids and taking their bronchodilators? Are those things helping their breath sounds get clearer? Are they moving air better? So do you see how we're moving through this process? Okay, now that is standard care. I'm taking care of this patient with pneumonia, and the patient has the expected signs of pneumonia. Now, the clinical judgment model has something called layer 4, and those are factors that may change what's going on with your patient. So how often do we have a patient that they have pneumonia and that's absolutely the only thing wrong with them? Well, for one thing, people with pneumonia and nothing else wrong, most of the time that gets taken care of at home. So if they're admitted to the hospital, they probably have some other things going on. So if they have pneumonia and they also have sickle cell disease, okay? Pneumonia can trigger a crisis. If they have pneumonia and they also have COPD, are we going to anticipate getting their O2 sats back to 100% before they go home? If they have pneumonia and they are unhoused, they live on the street, how does that change our discharge criteria? So there are things in the environment, and there are individual factors that change what's going on with our patient, or that change sometimes the priorities of care. And the idea of using clinical judgment in the nursing process is that you are looking at that patient as an individual, not as a canned set of steps. We're going to do this, then this, and this, and this. Okay. So that's a quick overview of the nursing process. We're going to end this recording here, and then we're going to talk about assessment in the next recording.